Thank you, everyone. And it's really exciting to see a full room this morning. The collaborative has grown, and it's still growing. This morning, I'll be talking about improving outcomes for people with diabetes, and I believe that that's why we're all here. We're all here to continue to improve outcomes for people with diabetes. My name is Ori. T1D Exchange is a national learning network with centers working to improve outcomes for people with diabetes. T1D Exchange has grown to a network of 63 centers from Nicole's slide. So you see that we're still growing. 62 centers for type 1 and 25 centers for type 2 diabetes. Our database currently has approximately 90,000 plus people with type 1 diabetes and 60,000 plus people with type 2 diabetes across 23 states. And this is our amazing QI team. Shout out to everyone in the room. And the amazing leader, Dave Walton. So this morning, I'm really going to talk about how T1D Exchange is transforming diabetes outcome through these 5 ways. We're doing this by collecting the right kind of data to drive real-world improvement. We use the data to make best decisions for the population of people with diabetes, and also to really understand and quantify factors that contribute to driving positive outcomes for people with diabetes. We design and test initiatives to improve clinical and population health outcomes, and we use all of this to then generate real-world insights. We collect the right kind of data through data mapping. I know that many of us are familiar with the process of data mapping. The T1D Exchange centers work with the coordinating office to map their EMR data to T1DX data specification. The process begins when centers connect to the T1D Exchange secure portal for file sharing, and it's complete after extensive testing and extensive rounds of data validation. For those that have been part of data mapping, you know that the process could be lengthy, but it's always worth it at the end. The goal is to make sure that we're mapping data accurately. For type 1 centers, we have 49 centers that are mapped right now, and 5 centers in the process of mapping. And for type 2 centers, we have 6 centers that are fully mapped their data, and 5 centers in the process as well. We also use data to make population health decisions, and we do this through the QI portal. Many of you might be familiar with the QI portal. It's an EMR-based data platform to review trends and benchmark T1D outcomes. I was really excited to see Georgia's presentation because some of the charts in her presentation were from the QI portal, and you could see that she compared a center to other centers. The portal allows clinics to display their data in the T1D Exchange measures that we track, like the HbA1c, CGM-Us, insulin pump, diabetes ketoacidosis, and other measures. The portal supports quality improvement initiatives. It informs population health insights. We're able to benchmark against other T1D centers, and also we are able to display the data by race and ethnicity, which could inform equity initiatives. Over the years, there's been increased engagement on the portal, and my colleague Alisa would be sharing about new measures on the portal and updates to the portal in one of the breakout sessions today. Another way that we're improving outcomes for people with diabetes is really understanding the factors that contribute to positive outcomes, and we do this through special projects. We have, over the last several years, we've completed more than 10 special projects, and the special projects gives us an opportunity to really brainstorm with PIs, really try to understand the factors that drive positive outcomes. And I'll talk briefly about some of the special projects that we've engaged in this year. CGM-Us in type 2, I'll talk about the Improve AID project, I'll talk about the T1D screening and monitoring project, the best practice advisory, and the type 2 working group. And you'll hear more about this project in breakout sessions over the course of the session. The first project I'll talk about is a multi-center QI project to increase CGM adoption in adults with type 2. The project aim for this project was to increase CGM use by 10% for adults with type 2. and to demonstrate a reduction in CGM disparities. We conducted this project with 3 adult centers, and the participating centers used the health equity framework to plan and to test interventions. There were tons of interventions. Some of them used diabetes technology navigators. They used CGM posters in clinics, CGM videos, online CGM classes, translating educational materials, and a host of other interventions. For this project, CGM use increased by 11% over the cost of the project. The Improve AID project is ongoing. There are 3 aims of this project. The first is to accelerate AID data collection and conduct real-world analysis, to complete qualitative analysis and to understand factors that influence diabetes provider recommendation of AID systems, and to increase the percentage of newly diagnosed patients prescribed AID. So there's a qualitative aspect of this project. There's also a QI aspect of this project. For the qualitative part of this project, 14 centers and a total of 40 individuals participated in focus group discussions, and transcripts were coded and analyzed for common themes. And for the QI aspect of this project, participating centers are utilizing the equity framework to test interventions and to increase early AID adoption. So far, we've had 1 oral presentation at ATTD and 2 posters for this project. It's still ongoing, like I said, but some of the key findings that I just wanted to highlight is the fact that mean HbA1c at 2 years is lowest amongst people with type 1 who initiated AID within the first 6 months of diagnosis, and there's need for more evidence to help create standardized guidelines for recommending AID system, which at present does not really exist among centers. I would also talk about the T1D screening and monitoring project. For this project, the study objectives are to develop and test diabetes centers' workflow for T1D autoantibody screening and monitoring in the real-world setting, and to identify care team perceptions of operational challenges to the screening and monitoring process. For preliminary results, 147 individuals screened from 2 centers, 13 individuals screened positive with confirmed result for multiple autoantibodies, 8.8% positivity rate of confirmed positive result. The second aspect of this project is to operationalize screening for stage 1 and stage 2 type 1 diabetes in clinic. And for project AIM, we wanted to increase by at least 15% from baseline the proportion of people screened for type 1 in 18 months, and to increase by at least 30% the proportion of eligible people monitored for progression to stage 3 type 1 diabetes over 18 months. And right now, there's 15% increase in the number of patients screened from baseline. The best practice advisory project, we call it the BPA Tech project. There are 3 aims of this project. The first is to develop and implement an EMR-based BPA using stakeholder feedback to standardize the approach for prescribing and documenting advanced diabetes technology amongst adults and pediatric centers. The second aim is to determine the effectiveness of an EMR-based BPA in reducing racial inequities in advanced diabetes technology. And the third aim is to explore the reasons identified for why providers decide not to prescribe advanced diabetes technology, and whether those decisions were people with diabetes or provider-led. And also to find the association between the reason provided and the people with diabetes, race, and ethnicity. For this project, we've completed the focus group discussions and completed analysis, and all centers' BPA has gone live. I would also talk about the Pediatrics Type 2 initiative. It's not a special project, but we're running it kind of like a special project. The aim of this working group is to demonstrate improved patient outcomes in pediatrics type 2 using QI methodologies, and to use benchmarking data to illustrate that a collaborative approach is feasible in pediatrics type 2. We have 25 centers as part of that group, and so far we've had 5 posters presented, and I'll just talk about some key findings from this group. There's a significant variation in demographics and key clinical characteristics across participating centers. GLP-1 and SGLT2 medications in youth with type 2 diabetes the uptake remains inconsistent and suboptimal across the sites. Baseline starting therapy average was at 25% for youth with LDL levels greater than 130 milligrams per DL, and there's low CGM use amongst adolescents and youth with type 2. The other way that we improve outcomes for people with diabetes is by designing and testing QI initiatives to improve outcomes for QI. And at this point, I think I'm, speaking to the choir because we're all familiar with QI methodologies and we all do QI. The T1D exchange, we use the model for improvement, and this is, you all are very familiar with that process. We use this to really understand local clinic processes, to identify contributing factors, to brainstorm possible interventions, and then we use PDSA cycles to test interventions and scale interventions in clinic. We have a lot of active QI projects right now. I won't go through this list, but there's projects around transition planning, around increasing CGM use, increasing social determinants of health screening, increasing AID use, and the list goes on. So thank you to everyone here for actively engaging in QI projects, and we've seen results over the years that the metrics that we're tracking, we're seeing improvement in those metrics through all the QI projects that you all are doing. And we've also seen that QI methodology works. We've had presentations to show that QI methodology has helped to increase pump use, CGM use, depression screening, and all of that. And we have many of these publications, you have access to them. In the last 3 years, we looked at the model for improvement post-COVID, and we really thought about how we could expand this model to help us with equity initiatives. So the whole idea of this project, of this framework, is to apply an equity lens when we're thinking about our QI project. So rather than, just do your QI project like you would, for this framework, it really helps you to think about, a patient in a population of your patient, and you're able to think about their social factors as well. You're not just doing the QI project, you're looking at maybe patients that don't speak English, or you're looking at your racial minority in clinic, you're looking at those on public insurance, and you think about ways that you can help them. And this framework has really helped. There's been a lot of publications that has also shown us that this framework has worked. We have used this framework with pediatric centers, with adult centers, and I won't go through this list, but we've seen 22% increase in CGM for non-white patients in a pediatric center. There was a decrease for loss to follow-up amongst non-white by 30%. We've also seen increase in CGM usage amongst publicly insured children by 32%. CGM use increased among non-Hispanic Black and also amongst Hispanic in an adult center, and the list goes on. We also have QI change packages. The most recent change package was earlier this year in April. It's the CGM equity change package for type 2 diabetes. I would encourage everyone to, review some of those change packages. We always say that you still shamelessly, whatever QI project you're thinking about, there's a center that has done it before. You really don't have to reinvent the wheel. There's always a place to start. So you can start by just even reviewing the change packages, going through some of the publications, and even talking amongst your peers to see what you can do differently. You can also talk to your QI coaches as well. Lastly, with all the things I've mentioned earlier, the QI portal, the mapped data, we then use all of this to generate real-world insights. I can't overemphasize the importance of the data that we have. We have a robust data infrastructure. We have over 100 plus publications in top journals with over 250 presentations at national and international conferences. So if you're here and you're thinking about, you have a research idea or a research question, there's a link, a Qualtrics link that you can fill, and you can put in your request. We have a whole team dedicated to real-world data, and they can help to answer, whatever research question you have. We're always open to that, and that's the whole idea of this work. And these are examples of real-world insight, equity related. And I'll conclude by saying that T1D Exchange is definitely positioned to continue to drive measurable and sustainable improvement in diabetes outcome. And we can do this, through sustained collaboration, continued data sharing, peer learning, the use of evidence-based QI methodologies, and by thinking about improving care processes together, and most importantly, by listening to the population that we serve and really trying to understand their unique needs. And I'd like to say thank you to all the PIs that are here. You all push us every day to do better. And I thank my colleagues as well, and really excited that we're all here in Atlanta. Thank you.